Yes, started. Okay. So yes, and after thank you to Zhenya Golovchenko as a coordinator and for all her help for nurses in the UK from Ukrainian Medical Charity, and for great speaker Steffi Ward from University of Derby. I would like to invite her to give you floor for starting workshop for OSCE series. And again, thank you so much on behalf of Ukrainian medical community in the UK.
You're welcome. You're very welcome. So good afternoon, everybody here. My name is Steffi and I am a mental health nurse. I'm also a PhD researcher at the University of Derby. My colleague David is tied up in another event this afternoon, but he would have been here. He is a critical care nurse by background, and he is also the head of the School of Nursing and Midwifery at the University of Derby as well. So what I'm going to do is share my screen, and then we can, just sorry, admitting people. I can share my PowerPoint with you, so just bear with me. So just checking you can see the first slide there on the PowerPoint. Yeah, perfect. So as I said, Vitaly Vas, and welcome to the second workshop in the series aimed at helping better understand what's required of you in the UK nursing OSCE. As I said, my name is Steffi. I'm a mental health nurse for those of you who've just joined, and I'm currently doing my PhD at the University of Derby, where I am researching into the impact of the Ukrainian armed conflict on nurses. My colleague David will be joining us later on today. He's tied up in another event this afternoon at the moment. So the focus of today's session is really to build on what we covered in workshop 1, and then look at the last 2 parts of the API nursing process, which is station 3, which is implementation station, medication administration, and station 4, which is the evaluation and handover station. So this workshop is not a technical workshop. It is not a practical medication administration session. It is a way of looking at what the examiners are expecting of you and trying to make it a bit easier to kind of get your head around everything. So the first thing I'm going to do is a quick recap of the assessment and planning station from workshop 1, which was the last workshop we did before Christmas, just to make sure everybody's confident with that. And then we're going to build on that, looking at station 3 and 4. And then we're going to look at what the OSCE is actually assessing, what assessors are looking for, and how these stations link directly to what you already know as nurses. And then finally, something that came out of workshop 1 was that you would like to spend some time just having a quick look at NHS clinical decision making for nurses, and how nurses in the UK are expected to think, prioritise safety and make professional decisions, and especially how that links into the OSCE. And as before, this session is about understanding the process. It's not about memorising any rules or trying to learn everything all at once. In the OSCE, care plans are assessed not as a single written document, but they're assessed through how you implement, evaluate, complete your documentation and hand over care. So that's what today is focusing on. So my role in this workshop is to help you navigate that process so that you can show your skills and experiences as nurses in a way that the UK OSCE assessor is looking for. So I'm not here to teach you how to be a nurse again. I'm just here to help you build on what you already know and transfer that across into the OSCE style. So there's going to be time at the end of the session to ask questions. So if something is a bit unclear or it feels confusing, please do ask at the end of the session. The chances are there are other people in this session who are thinking the same thing. So all of the information in this session today comes from the Nursing and Midwifery Council, the NMC, their OSCE preparation guides, and also the mock OSCE papers. So the links for all of those documents are at the end of this PowerPoint. So just a couple of bits of housekeeping before we get going. I wanted to ask if you can keep your microphones off or muted while I'm teaching during the workshop, unless you're responding to a question that I've asked or you have a question. If you've got a question, please pop your hand up on Teams, and Eugenia is watching the chat for me, just making sure that I don't miss any questions. The workshop is being recorded today, and it's going to be added to UMAUK's resources afterwards. And I will also forward this PowerPoint presentation as well. And as I said, if you've got any questions, you can pop them in the chat or raise your hand, and we will stop for questions at the end of the session. So there might be some discussion points that people want to raise as well. So just to reassure you and be clear about any expectations that you have from today, you do not need to memorise long lists of medications for today. We won't be performing any clinical skills today. You don't need to remember every single framework that we talk about. But what you are building on today is the understanding of how the OSCE is structured, what examiners are looking for, and how nurses in the UK think about safety and decision making. It's how your care plan is judged in action, not about filling the forms in. So it's about understanding the process, not about being perfect. So with that in mind, I wanted to kind of touch base on something that came up in the last workshop. So there was quite a number of questions around English language requirements in the last workshop, and it's very understandable to be worried or feel anxious about that English aspect of what the NMC are asking for. Obviously, the OSCE is not an English language exam in itself, and the assessors are not judging you on your ability to express yourself in English or if you have perfect grammar. What they are judging you on is whether you can clearly and safely communicate as a nurse. So you don't need to sound like a native speaker, as long as the examiner can understand what you're doing, why you are doing it, and when you would escalate, and you're explaining that clearly, then it's enough. It really is enough. You do need to achieve the OET or the IELTS English exam pass, but what I will do at the end of this session is have a quick look at that and what that means and what those points are and things like that. So we will come back to things like communication skills during the session, but I don't want you to worry about your English while we're learning together today. If you've got specific language questions, we can also cover those at the end of the session as well. So just a quick question before we start, and to give me an idea of what types of nurses we have here today and what kind of nursing experience people have had. It would be really useful to know what field of nursing you're all from. Last time we had a bit of a mix, so maybe just pop into the chat if you can, whether you're an adult nurse, mental health, children's nurse, learning disability, or maybe you might even be a midwife or a medic. And it just gives me an idea so that I can think about that as we're going through the workshop. So I'll just give you a couple of seconds just to pop that in the chat for me. So have we got any adult nurses here? mental health nurses, children's nurses, adult. Perfect. Thank you, Mariana. Theatre. It's just really nice to know the different types of nurses we've got here.
Steffi, may I explain a little bit about our system in Ukraine? Most of our nurses, according to the UK classification, are adult nurses. In Ukraine, we all are general nurses, and then only when you start practice, you can choose your field of work. Some nurses go to children's department, some nurses go to theaters, and that's why most of us will apply for adult registered nurse in the UK.
Yeah, that's what I figured it would be, but I just thought I would check because I can, like we did last time, make sure that I'm being clear about the small differences there are, because for the nursing OSCEs, for the different branches of nursing, there are some subtle differences between them around what's expected or additional things that you need to do. So it's just good to know, but I totally understand. Yeah, completely get that. So what we'll do then is, and I'm just double checking as well, we've got no midwives this time and no medics, because if anybody is from the midwifery field or a medic, you will see some common elements in the nursing OSCE to your professional OSCEs, but there are also a lot of differences. So you will need to refer to your own professional OSCE specifications, just to make that clear before we get going. So just a very quick recap from workshop 1. So because I felt like it was a good starting place for us. So in workshop 1, we looked at this model, which is the API model, the nursing process model. And we focused on the first 2 of the OSCE stations, which is the assessment station and the planning station. And that is where the first parts of the care plan are formed. We looked at how to identify nursing needs, how to think in terms of cause and effect, and also how to plan safe care and nurse-led interventions within your scope of practice. So I'm not going to reteach those today, but we're going to build on them by looking at the next 2 stations, which is station 3, which is implementation, and more often than not, that is medication administration, and the final station 4, which is evaluation and handover. And those last 2 stations are where your care plan is demonstrated in practice. The OSCE separates these into different stations, but the thinking is continuous all the way through. So in the first workshop, we looked at these 5-step thinking models. So we had one for station 1, which was the assessment station. And we moved through this process and we identified 2 nursing needs and 1 linked to the presenting problem, and 1 was linked to the impact on the activity of daily living, or ADL. In the planning station, we used same 5-step model to look at what can a nurse do safely next by choosing a small number of nurse-led actions. So we used the information from station 1 and your A2E assessment to decide how we were going to plan those next steps. And this thinking follows a clear step-by-step process. Even if you're not consciously naming it every step, the implementation and evaluation stations build directly on these 2 stations. Nothing changes, we are just moving it forward into the next station. We also looked at the first 5 seconds of safety. And I put these two things together, which was HIPEPS and SOLAR, because those same professional behaviours run through all of the OSCE stations. And HIPEPS keeps you safe and professional, and SOLAR supports person-centred communication and also in your A2E assessment as well, and it helps you recognise risk. With HIPEPS, those are the core safety behaviours that are expected of nurses in the UK. And these are things that the assessor will look for automatically. It's not about saying them out loud, it's about how you demonstrate those behaviours in everything you do across the OSCE. So that's everything from hand hygiene, how you introduce yourself to the patient, how you gather information off the patient and check for allergies, how you explain what's happening and gain consent for those things. Also, as well, how you might assess somebody's ability to consent to something, how you maintain their privacy and dignity, and how you would safety scan the area. SOLAR is quite a common communication model, and you can use that to communicate with patients, family members and carers, but also your own colleagues. It shows the assessor that you are being calm, that you're respectful, that you're attentive to the person in front of you, and you're also acting in a professional way. Again, it's not about performing it, it's about communicating as you would with a real patient. So whether you're assessing a patient, planning care, giving medication, or handing over, HIPEPS and SOLAR are there, and they're always being marked. So you'll see on the slide that there's like a little magnifying glass in the corner, and that's to remind you that even though you might not necessarily be saying some of these things out loud, the examiner is looking for them. The assessor is looking for them in how you are acting as a nurse in that scenario. So they're not separate tasks, they run quietly in the background of everything that you do. So as we move into implementation and evaluation, you will see how the HIPEPS and SOLAR support safe decision making, especially during things like clinical skills and medication administration. So if you see the magnifying glass, when you look back on this presentation afterwards, remember it's across every station that the examiner, the assessor is watching for safety, structure, communication and professionalism. So I'm not going to pause for questions at this point. We will do questions at the end. And as we work through the implementation and evaluation stations, it will all be a lot clearer and drop into place. So as we move on to station 3, which is implementation station, it simply means that we are doing the plan that we started in station 1 and 2 safely. So implementation is where the assessor can see whether your care plan can be carried out safely in practice. Everything you assessed and planned in stations 1 and 2 lead to this point. In the implementation station, you are not being asked to do everything, you are being asked to carry out one safe nursing action. So in adult nursing, and more often than not, this is a medication administration session on this station. If you were to be in mental health, there might be aspects of this which are around therapeutic communication or de-escalation. And if it was learning disability, it might be about adapting care and communication to suit the needs of the patient. And if it was in children's nursing, you would be usually combining medication with family-centred care. So the thinking process for all of them, safety, judgment, communication, and escalation are exactly the same. It sounds scary, but it's important to understand what the examiners, the assessors, are really looking for. They're not testing for complex pharmacology knowledge. They are testing for safe nursing practice. So they're looking at how you check, how you communicate, how you recognise risk, and what you do if something is unsafe. It is completely acceptable and sometimes correct in an OSCE station, an OSCE scenario, not to give a medication because it is unsafe. As long as you can clearly explain why and escalate it appropriately in the handover. And this is where everything that you've already learned comes together. You can see on the slide that we have the 6 rights of medication administration. And this helps you with your check-in process when you come to this station. Your A to E assessment that you completed earlier on can inform the decision about what's the safe action to do right now. And HIPEPs and SOLAR ensure that you are practicing safely, professionally, and communicating in a person-centered way. Some of you might have seen this as 10 rights in other settings or come across a different version, which are kind of helpful for a reflection, but for the NMC OSCE, they expect you to look at the 6 rights, and that's demonstrated through safe practice. So we're not going to do a technical steps of medication administration today. What we're looking at is how the assessor thinks, so that when you come to this station, you can take it a bit more in your stride. When you get to this station or at the beginning of the OSCE, the assessor will indicate to you where the medications are for this station. It will only be the medications that you need for this station, for the medication administration station. They might be in a cabinet, they might be on a tray or in a box or something similar, but you're not expected to have to go and search through a really big drugs trolley to go and find the medications or go all the way to the back. They will show you where it is, they will tell you where it is. This whole station is designed to assess safe nursing decision making, not your ability to find a piece of equipment. So if this looks familiar, it's because we're using the same 5-step thinking that we used earlier in the first 2 stations, the assessment and planning station. The difference is that now we are doing the plan. So this is essentially your 6 rights in action. It's not a checklist, but it's a way to help you organise your thinking, which might be helpful. So the first step is to start safely. And here is where your HIPEPs and your SOLAR fit in. The first thing that the assessor is looking for is basic safety and professionalism. And this applies to all fields of nursing. So this is where we have the hand hygiene, introductions and identity checks, all of those parts of HIPEPs that we talked about in workshop 1, around identity and allergy checks, consent, privacy, being able to explain. If safety isn't there at the start of this station, it will undermine everything else. So the second step is to check the chart. So this is where what we call prescription validity sits. So a valid prescription is one that is complete, it's clear, it's signed, and it's safe to act on. But what does that actually mean? So when you're looking at prescription validity, you are checking that the prescription is signed, that the prescriber's handwriting is legible, and it's clear to understand the drug, the dose, the route, and the timing, and that it makes sense for this patient. If you feel that there is anything missing or unclear, the medication should not be given until it is checked. So when you're checking for prescription validity, that's one of the things that you're looking for when you are doing a full reading of the medication administration record, the MAR chart. And during the OSCE, you would do this out loud so that the assessor can see and hear that you are doing this safely and can also understand your rationale for questioning things or for asking additional questions. So I would already at this point be thinking in my mind, is this medication safe? Is it appropriate? And is it indicated for this patient right now? The explain and decide is the most important step of this process. And it's where you show the assessor your clinical judgment and decision making. You explain what the medication is for so that the assessor can hear you and they can see how you would explain that to the patient so the patient understands. At the same time, you're deciding if it's safe to give them medication right now. This is where your A to E assessment from the assessment station matters. You may have, for example, a drug on the MAR chart for hypertension or diuretics that you need to administer. But you might need to ask the assessor for a more recent blood pressure reading. If they give you a blood pressure reading that's low, it may not be clinically safe to give that medication. So you might have to omit it. And you would note that omission on the chart in the correct place with the correct omission code. And then you would carry that forward and escalate it in the next station during the handover. So the same thinking applies across all fields. For example, in mental health nursing, we might be at the explain and decide. We might be looking at whether the person has capacity. We might have to look at their current mental state. Are they having any side effects from their current long-term medication? In learning disability, I might be thinking about reasonable adjustments or how I would assess the patient understands what's happening. And in children's nursing, we might be looking at a weight-based dose or the timing of previous medications and also information from parents. Deciding not to give a medication is still safe nursing care as long as you can justify, document and escalate it. So step 4 is dispense and administer. So if it's safe to proceed, you would then go and prepare the medication and administer it following NMC guidance. And the assessors are looking for calm, safe practice. They're not looking for you to be super speedy. So safety checks continue during the preparation and administration. And this again, 6th rights and safety checks for medication. So that's checking the date, checking labelling, dosage, if there's any patient details on the box, if it's a patient specific medication, and checking that against the MAR chart. And preparation also means checking that the form and method are right for this patient. So that might be liquid versus tablet. Can they swallow it safely? Or is there an appropriate device available to administer it? I'm also might be thinking ahead about what I might monitor after I've given them the medication around effectiveness and side effects. And I would be thinking again about allergies. We checked them earlier on when we spoke to the patient during the assessment and planning stage. And I would be thinking about allergies again here and looking at the medication that I'm going to administer and think about my patient. We still need to think about those things when we're administering and dispensing them. And then the final part of this stage is the documentation and the close. So the station is not finished until the documentation is completed and you've signed correctly or you've recorded non-administration omission using the right code that's indicated on the MAR chart. And also it's about being clear about where it might be signature only on the chart, where it might be signature and time, where you might need to include the correct code and signature. So as we said earlier on, if you've not given a medication, you've omitted it, or you had any concerns, then you would need to ensure that this is clearly documented on the MAR chart and escalate it at the next station in the handover. Safe documentation is part of safe nursing, and only then could you close the interaction on this station. So I wanted just to pause and think about something important, because there might be some of you who are familiar with community medicine administration record charts, or more familiar with inpatient ones, and they can look very similar, but they are used differently. So an inpatient one, an inpatient MAR chart, often has multiple pages, and they include regular medications as needed, or PRN medications, and also once only or stat medications. They may also have oxygen charts on there as well, and omitted medications. You might have come across other pages on MAR charts as well, but it's important that you look at all of those pages. In an inpatient setting, care can change quickly. So medications can be started or stopped, given in different areas such as A&E, and that's why it's really important to read all those pages on the chart. In a community setting, the MAR charts are often shorter and they're more stable in a way. They usually focus on regular and PRN medications over time, and there's less risk of duplication from recent once-only doses, although sometimes in a community setting, you might have more complex charts, for example, if it was palliative care or end-of-life care. You're not expected to know every type of chart, but you are expected to be able to recognise risk and check for it carefully. So in the OSCE, it's more likely you will be working with an inpatient style MAR chart, even if you've got more experience in community. In the NMC preparation documents on their website, there are examples of completed MAR charts, and I think it's really useful if you have a look at those and familiarise yourself with what you might see in the OSCE. But this is why, as we said earlier on, prescription validity means checking the whole chart, not just the patient page in front of you. So I've put this table here, not to memorise it, but to show mistakes or high-risk moments is a better description in this particular station, in the implementation station, medication administration. So these are not about knowledge, they're about pausing under pressure. If you slow down at these points, you protect not only your patient, but you also protect yourself. So as we said, prescription validity, you must read all the pages of the MAR chart that you get in the OSCE. Skipping pages can mean missing medications, once only drugs, or important information. Reading the chart out loud helps the examiner to see that you are checking it properly. For allergies, it's not enough just to ask the patient. For each medication, you need to ask yourself, is this drug safe for this patient? So it's about linking allergy information to the medication in front of you. Once only medication, a once only drug may appear on a different page on the chart. You need to check when it was last given and if it was given recently. So you must not give it again, and you must document why. It's good nursing practice, not a failure, and the reason all the pages on the MAR chart need to be read. For as required or PRN medications, these are prescribed for a reason. So one of the things that when I was looking at the NMC information was that often OSCE candidates can skip over these and feel like they don't need to read them, but actually you do need to read them, and you need to make sure you're offering them to the patient if it's appropriate. Not offering a PRN medication that is on a MAR chart is seen as missed care, and it can be a critical fail. So that's something that's important to do. The final high risk moment is your documentation. The station is not finished until all your documentation is completed. So that's date, time, and signature for the medications that are given, as well as recording non-administration or omissions clearly. Any codes you need will be on the MAR chart. So safe documentation is part of safe nursing. Everybody finds this station challenging, but what matters is recognising these moments, responding safely, and pausing. So I thought it would be useful to have a quick look at an example of thinking that you might need for this particular station. Some of you will remember Mrs. Danilova from workshop 1. We assessed her and identified pain as a priority need, and we planned appropriate care. We're now going to implement our care plan from stations 1 and 2 and administer her medication. As we look at her MAR chart, we notice the following. Mrs. Danilova was given 1 gram of paracetamol after she arrived in A&E at 4 p.m. On her inpatient MAR chart, she has 1 gram of paracetamol prescribed as a regular medication at 6 p.m. We are now with her at 5 p.m. Is it safe to administer her regular dose of 1 gram paracetamol? This is a care plan for decision. Do we continue, adapt, or withhold the planned intervention? So if you would like to drop in the chat, do we give the 1 gram of paracetamol or not? And if not, why not? So if you would like to drop your answer in the chat. Or you can pop your hand up and say out loud. So she had it in A&E at 4. She normally has it at 6, but it's 5 o'clock. Is it safe to give her paracetamol? Mm-hmm. I'm just waiting. I can see people typing. Yeah, perfect. Well done. So you're quite right. Paracetamol is usually given every 4 hours. So at 5 p.m, it's too soon to give it again. Even though it is prescribed, you are correct. It is not safe to give it right now. The safe action is to withhold the medication. So as long as you can explain why to both the assessor and to Mrs. Danilova, and you document that it's not given because it's not yet due, using the right emission code on the MAR chart, that's good, safe nursing practice. It shows that prescription validity checking, it shows your clinical judgment and patient safety. And this is why it's important to read all of the pages on the MAR chart and check timing. It matters. So once you've made that decision, the next question is, has the patient's pain improved and are they safe now? And that is evaluation. So we've made the safe decision. The assessor will expect you to complete the action in the documentation. So this part should feel a bit more familiar. So far we've discussed about checking and decision making, and also when it's correct not to give a medication. And that's because unsafe decisions are where candidates most often lose marks and where practice can feel most different, possibly from what you're used to. So all this is evidence that your care plan has been safely implemented. So when you're happy it's safe to proceed, the assessor will expect you to prepare and administer the medication safely. You will continue your safety checks and then complete documentation. So you are checking the medication you have matches the prescription on the MAR chart, that it includes the drug name, dose, route, timing, and expiry date to protect against over or underdosing, the wrong drug being administered, or missing a medication altogether. You are still thinking about safety. And also remember, nursing doesn't stop at the drugs trolley. Even when the decision is made, the assessor is still watching how you nurse the patient, how you dispense the medication. So when you return to Mrs. Danilova to administer the medication, you are still being assessed. So think again, there's the magnifying glass. The assessor's looking for that high PEPs. It's looking for solar. He's looking or she is looking for solar, clear communication, appropriate eye contact, behaving in a professional manner. How you explain what you're giving and why, and how you check that she is consenting and happy to proceed. The assessor is not expecting you to narrate every single step at this point. You just need to show safe professional nursing behaviours while you administer the medication. And that's integral to your actions. So after you've administered the medication, you will complete your documentation. Remember, the station's not finished until your documentation's done. So make sure you double check that you've signed, time, dated, omission codes. And also remember, you never sign for a medication before the patient has taken it, or that you've also administered with the patient's consent. So while we're not practicing those technical steps in this workshop, we are understanding about what the assessor's looking for, so that you can feel a bit more relaxed and a bit calmer when you come to this station. I'm going to move on to the evaluation station, which is also the handover part of the OSCE. So we've done the A2E assessment on station 1. We've planned for care in station 2. We've done our medication administration implementation in station 3. And we're now moving on to station 4, which is the evaluation station or handover. And that is mostly purely a verbal station. So you're being assessed on what you say, not on how much you're writing. Your marks at this station come from your verbal handover that you give to the assessor. It's where you explain whether the care you planned and implemented has helped the patient, if the patient is safe now, and what needs to happen next. You may be given time to make notes, and you can use the notes that you've brought through from station 1 and 2 to help you. And you're showing the assessor that you're not just completing a task, you're reviewing the outcome and you're thinking ahead. Remember, evaluation, your notes from the earlier stations support you, but the marks come from what you verbally say on station 4. So most evaluation stations use what's called an S-bar structure for the verbal handover. And that is situation, background, assessment, recommendation. So SBAR is not really a script, it's a structure that helps you organise your thinking so your handover is clear and it's safe. It's not about perfect wording or long sentences with lots of complex language. If you keep it simple, clear, factual and safe, avoid using abbreviations that are not universally recognised. And if you're unsure, say the word in full rather than use the abbreviation. So the situation is your who, where, what's happening and how urgent it is. It's not a big long story. It's just simple, clear and factual. Your background, you need to make sure that you're including why they are here, why are they in your care, and key history points that are relevant to what's happening now. You need to make sure you include any allergies and current meds if it's relevant to the problem, but you don't need to include a massive in-depth exploration of that person's medical history if it's not relevant. A stands for assessment and it needs to be objective. So that means what you observed, measured and assessed in your A2E assessment. And that can include as well behavioural or mental state observations where they're relevant. It's not about diagnosing or labelling the cause, but it is, if you're worried, say, I am concerned because. And then in the recommendation part, it's about being specific. What you want done, when, and what to do if something gets worse. So maybe don't end with continue to monitor with no plan. You might say include escalation with thresholds where it's appropriate. SBAR is the same way nurses hand over every day in nursing practice across all nursing fields, but there are some slight differences. So in adult nursing, you'll be using deterioration cues such as news to or observation trends. You might be looking at pain, mobility, wounds, fluid in, fluid out, and also explicit escalation if you suspect deterioration. For mental health, we would be adding into that things like mental state and risk. So risk of self-harm or suicide or vulnerability, whether the person's got capacity or if there's any observation levels or safety plans in place. Similar things in learning disability around distress cues, reasonable adjustments and safeguarding concerns. You would also flag those up in adult nursing as well if you had safeguarding concerns. And again, for children, it's around age appropriate observations, pain scores that are appropriate to their age, parental carer concerns, medication timings and weight considerations. We might also have weight considerations in adult care as well. So the OSCE is asking you to show that you can do this safely and professionally. So an easy way to think about it might be if you can see it, measure it, or assess it as a nurse, you say it in your SBAR. So that might be his blood pressure is 88/54. The news 2 score is 6. The patient has reported pain level of 7/10. The patient's speech is pressured. The parent states that the child is reduced intake. They require easy read documents and extra time to think. If it requires diagnosing the cause, you should escalate it, not label it. So remember, nurses describe what they see, measure or assess, not diagnose. So I thought it might be useful to use Mrs. Danilova to have a look at what an S-bar handover sounds like in the OSCE. So it's not about perfect wording. Remember, it's about clear thinking, clear concerns, and clear actions. So this S-bar shows medication decisions are part of evaluation and escalation, not just administration. So it's not just implementation. Remember, in this evaluation station, the handover, you're assessed on what you say, not how long it is. So this S-bar is at nursing level, not medical level. In the situation, S, the nurse identifies who the patient is and why they are concerned. In the background, they give only the information that matters right now. In the assessment, they describe what they've seen and measured, not a diagnosis. And in the recommendation, they explain what they have done, what they are worried about, and what they want to happen next. I want you to notice something important in this example. The nurse clearly explains that paracetamol was withheld. They explain why it was unsafe to give, and they explain that this decision was documented correctly, which is safe nursing practice. In the OSCE, the assessor is listening for this kind of reasoning. You score marks for recognising risk, making a safe decision, and communicating it clearly. If you notice on this S-bar example, the language is simple, the sentences are short, and the facts are clear. There are no medical diagnoses, abbreviations, or jargon in there. I think the only abbreviation on there is News 2. This is exactly the level expected in the OSCE. You don't need to memorise this S-bar, but I want you to understand the thinking behind it, because when you come to your OSCE, this is how you show evaluation, judgment, and escalation. If your S-bar is clear, safe, and honest, it's good enough. So we saw this diagram in workshop 1, and we've seen it here today in workshop 2. And I want to finish by bringing everything together. In workshop 1, we focused on the writing of the care plan. We practiced and we looked at assessment, identifying nursing needs, and planning care. Today, we are closing that loop by focusing on the implementation and evaluation of that care plan. So implementation is where the plan is put into action, your medication administration. And evaluation is where you show whether the care plan worked, whether the person is safe, and what needs to happen next. So together, workshop 1 and 2 show the full care planning cycle. It's not just how a care plan is written, but how it's implemented, evaluated, and then communicated. You've already have the nursing skills that you need to do all of this. This is just about showing them how you do it in the UK system. So I want to finish this section by showing you this slide. So this is the wording from the mock adult nursing OSCE from the NMC paperwork. And it shows how the OSCE care plan is demonstrated. You can see that the care plan in the OSCE is not a single document. It's demonstrated across 4 linked stages. In workshop 1, we focused on the first 2 parts. You practiced A to E and holistic psychosocial assessment, identifying nursing needs, and planning appropriate care, which is where the care plan is formed. In workshop 2 today, we focused on the next 2 parts. We looked at implementing care safely in medication administration and evaluating it through professional communication in your handover. And this is where the care plan is demonstrated to the assessor in practice. Taken together, these two workshops cover the full OSCE care plan using the API nursing process. So it's not just how it's written, but how it's carried out, reviewed, and communicated to meet the NMC standards. Nothing on this slide should feel unfamiliar to you now. What the OSCE is asking you to do is what you as nurses do every day. Think safely, act professionally, and explain your decisions clearly. So, in the feedback from workshop 1, there were 2 additional things that you asked me to cover today. And these are the final teaching points for this workshop, I promise. The first was around clinical decision making for nurses in the NHS. You've seen this pyramid before in workshop 1 when we talked about evidence-based practice. I want to show you how this model explains clinical decision making for nurses within the NHS. In the NHS, safe nursing action sits at the centre of every decision, and those actions must be justified. The first part of that justification is best evidence, and that includes NICE guidance, national standards, and also local policies. In the OSCE, this might sound like I would monitor respiratory rate to detect deterioration early, in line with NICE guidance. The second part is your clinical assessment and judgment. And this is where your A2E assessment, Muse 2, pain assessment, and other observations sit. The third part is the person. What does this patient need right now? Are they in pain? Are they anxious, at risk? Do they lack capacity to make their own decision? And this is where person-centred care and dignity matter. In the NHS, a good nursing decision balances all 3. It's not just policy, it's not just task completion, and it's not just preference. This model explains why UK registered nurses are expected to make autonomous clinical decisions within their scope of practice, while they work collaboratively within a multidisciplinary healthcare team. You're not waiting to be told what to do. You are expected to assess, justify, act, and explain your reasoning. In the OSCE, assessors are listening and looking for this thinking. When you explain why you did something, you are showing evidence, assessment, and patient-centred care. In many healthcare systems around the world, nursing decisions are more medically directed, but in the NHS, as a UK registered nurse, you are accountable for recognising risk, deciding what is safe, and escalating when needed. The OSCE is testing your ability to show that thinking. So put simply, clinical decision making for nurses means that we assess, we justify, and explain our decisions, not just carry out instructions. So the second request from workshop 1 was clarification around the language requirements for the Nursing and Midwifery Council. So let's look first at what the NMC requires. So you can see on this slide that it's showing the exact wording used by the NMC in their language requirement document. They require you to demonstrate that you know enough English to practice safely and effectively. So this is equivalent to the Common European Framework of Reference for Languages, level C1. Now the NMC will accept different ways of showing this, and the most common ones are the Occupational English Test, the OET, and the International English Language Testing System, IELTS, And both are different tools, but they measure the same level. They show that you can communicate in English clearly, safely, professionally, but it's not about being perfect. It's about being understood at work. So for the OET, nursing candidates are usually expected to achieve a grade B for speaking, which is 350 points or more, listening and reading, and a C+ for writing, which is over 300 points. For the ECLs, it's usually level 7 overall with a 6.5 for writing. So just for comparison, a native English speaker would potentially score a level 9, but the NMC are not looking for that level. So the OSCE is designed around these levels of English. It's not expected that you will use complicated vocabulary or long sentences. It's testing whether you can work safely in English, not whether your English is perfect. If it sounds a bit intimidating and overwhelming, I thought it might be good to see what that might look like in everyday nursing terms. What does that mean as an everyday nurse? And you can see that this is about being understood and working safely, not about being perfect. So a nurse with a professional English level can explain what they are doing and why. They can understand their patients and colleagues and instructions. They can ask for clarification when something is unclear. They can give a structured handover, such as an SBAR, and they can escalate concerns clearly. They use professional but simple language, and they can be understood. And these are safe nursing behaviours, not advanced language skills. So before we move into the questions, I want to quickly come back to the aims of today's session and acknowledge something really important, if I can get my words out. We've revisited the nursing process, A2E assessment, identifying nursing need, planning safe nurse-led care, and that connects directly to the work that we did in workshop 1. And today you've seen how that care plan is put into action, how safe decisions are made, including when not to give medication, and how you evaluate care using a verbal handover and the SBAR. We've looked at how nurses make autonomous decisions within their scope of practice, supported by assessment evidence and patient needs. We've considered how that thinking is assessed in the OSCE and how it applies in NHS clinical decision making for nurses. And lastly, we clarified the English language requirements for the NMC registration, and we looked at what that means in reality and what a professional level of English looks like in everyday nursing. Taken together, these 2 workshops show the full OSCE care plan. It's not just how it's written, but how it's implemented, evaluated, and communicated safely in English. And I wanted to note that I know many of you are already experienced nurses. You have assessed many patients. You've made very difficult decisions. You've worked with very limited resources in the past, and you kept people safe in extremely challenging situations and circumstances. You bring so much compassion, professionalism, and real-world experience to your nursing practice, and all of those qualities will shine through in your OSCEs. What the OSCE is asking you to do is not become a different kind of nurse. It's asking you to show all of those existing nursing skills in the UK structure. And when you assess a patient, prioritise risk, decide whether an intervention is safe, explain your actions and hand over clearly, you are already doing what the OSCE requires. The difference is just how it's structured, how it's documented, and how we verbalise it. Your clinical judgment, compassion and professionalism are all there already. The OSCE is simply a translation of that into a UK nursing practice system. So we have some time for questions or comments if anyone would like to put their hand up or pop a question in the chat. And I'm going to stop sharing the PowerPoint while we do the questions so that I can see you all. And if anybody has any questions or they want to drop anything into the chat, please feel free. I've kind of tried not to put a lot of information in there, but there was still a lot of ground to cover. So any questions of anybody?
Guys, does anyone have a question? Okay, may I ask a question?
Of course.
Steffi, what would you recommend? What nice guidelines would you recommend to pass OSCE? What our nurses should read in first part? I understand that as much as possible, but maybe we can first stand for.
I would say the first place to go is to look at the NMC OSCE preparation stuff, because in there is references for further reading. So that would be a really good place to go to. And I would say the other thing would be to have a look at the mock papers, the OSCE mock paper for your nursing field, and go through the mock and make notes of terminology that you're not sure of or any reference points that you're not sure of, and then go to those further readings and look at those there. I think have a look at on the PowerPoint. In fact, I will share my screen again and we can see my references slide, because that will be helpful for people. So just bear with me 2 seconds. Sorry, it's slow. And again, as I said at the beginning, I will send you this PowerPoint as well. So
thank you.
So here, this is some useful resources. So the recognition of acute deterioration, or ROAD, is a really good one for having a look at things like the news 2 and where you escalate, where you have sepsis concerns. So that's a good one to have a look at. Geeky Medics is always a good place to start. They have lots and lots of OSCE information on there. They do have part of that website is free, but they also have part of it that you have to pay for. But there's lots of resources in the free bit which are really useful to use. We also have, these are all the references for the NMC documentation. And also I've put on there the reference around clinical decision making as well, which is the article that I thought would be really useful around thoughts around clinical decision making. So I put that on there as well for you. But I would say the NMC documentation is a good place to start. Look at their extended reading list and their suggested reading, and kind of go from there as well. Were there any other questions that anybody had, or anything that anybody would like to comment on, or you'd like me to go back over?
Дівчата, у кого є питання будь-які до Стефі? Тому що вона тут, щоб нам допомогти.
No.
Any questions?
What I have is, oh, Okay, we've got one coming. Somebody's typing. There's lots of information to take in, lots of things to think about. Not as much ground to cover as we had in workshop 1. There was a lot of ground to cover in workshop 1. And I know the OSCE, there's a lot of information there around it. But you can build on it, and you can build on your confidence with it.
What about clinical skills? Is it possible to prepare them in a right way to present on the OSCE without exactly practice?
Yeah, I think there are like OSCE assessment centres, aren't there? There are companies that do OSCE preparation sessions, and I believe they cover things like clinical skills and things like that in there. There are, if you have a look on YouTube, there are lots of videos around OSCE preparation, around clinical skills and things like that. And also as well, it's useful to have a look on, I will look out some links for you and I'll send them to you, Evgenia, and then you can share them, that we use with our undergraduate nurses, where they're learning things like aseptic technique or ANTT, which you need for doing cannulation and intravenous and also wound care. Or if you're inserting catheters, things like that. And some of those are really useful because it gives you, you know, sort of stage by stage aspect of what that clinical skill would be. So, you know, I can share some of those with you as well.
Yes, I think it would be useful because I heard that a lot of nurses fail on exactly a entity station.
ANTT. I mean, I have to say, even like undergraduate nurses, you know, student nurses here in the UK, aseptic technique, ANTT, is tough. It's tricky and it's hard to do. And it's really frustrating as well. I remember when I was training to be a nurse and I learned about ANTT, I was so frustrated all the time. There was always something that I put in the wrong place or I touched when I shouldn't, and it drove me mad, drove me crazy, and it took me ages to get my head around it. So I think it's not an uncommon thing for ANTT, aseptic. It's hard. For those nurses that you have where you're working, you know, you might be working in a theatre setting. I know somebody said they were a theatre nurse before. You might have work at the moment where you're working in a healthcare support capacity in a theatre setting. That gives you really good opportunities to, you know, kind of brush up on some of those skills as well. So I can see what courses can we take to prepare for the OSCE and feel more confident. I think the confidence thing is building on knowledge and seeing where the skills that you already have, how they fit into the OSCE, I think, and that will help build your confidence. I think I'm not sure if, Evgenia, do you have a list of training providers that you recommend or?
No, we don't have.
No, so I think you just have to have a look what's in your area in terms of training providers who are offering OSCE preparation courses, and just have a look what's close to you, I would say. I know the assessment centres are few and far between, which means you might have to travel away to actually go and sit your OSCE, but there may well be a training provider that's closer to you. I don't know the answer to that question. I think you would need to speak to the NMC. I think you would
Victoria,
need to
do you have nursing diploma from Ukraine?
And also as well, don't forget the OSCE is only one part of becoming registered with the Nursing and Midwifery Council here in the UK. You also have to sit the CBT, which is the computer-based exam. So you need your CBT pass, you need your OET or your English language equivalent, and you will need your OSCE.
You can check with NMC, as Steffi said, but I believe that unfortunately you couldn't be a nurse in the UK.
No,
because they are quite strict.
Very strict.
You need, yeah.
I think you'd need to perhaps look at the GMC, maybe the General Medical Council, about what you would need to become a medic here in the UK with that, Victoria. Again, the CBT, I believe that there are CBT training providers as well. Is there, because I was looking at the OSCE side of it, on the CBT side, Evgenia, is there a particular training that people can do for the CBT?
I looked at providers, but I didn't find even for myself. I do preparation on my own. I found only some materials. There are a lot of different videos on YouTube.
Yeah.
And that's all.
Wow. Okay. Okay. So, and maybe I will add that to my list. And see if I can find some information.
Maybe they can something do around the CBT, because it is seems a little bit easier than OSCE.
Yeah, but you still need both, don't you, for the NMC? You need the CBT and the OSCE. If the OSCE is your practical demonstration of your skills, the CBT is your computer-based demonstration of your knowledge.
Yeah.
If you look at it that way.
Yeah, and it is this test. You should find only the right question, and it is better if you know it, not guess.
Yeah. So I think, is it multiple choice, the CBT?
Yeah, it is multiple choice. Yeah.
Okay, so there is a QR code on screen if you've spotted it already. And I've dropped a link into the chat, which is just for a feedback form about today's session. It only takes 2 minutes to complete it. And I really appreciate the feedback that you guys give me, because it helps me plan the future workshops and future things that we can have a look at. As I said, those are some useful resources that I found, and I will have a look for some of the others. And these are the references from today's session. And then, as I mentioned at the beginning, I'm currently doing research looking at the impact of the armed conflict in Ukraine on nurses. This is information about my research, about my study. It's completely separate from today's workshop. And I'm looking at lived experiences of nurses. There's no expectation or obligation to take part, but if it's something you might be interested in, you can have a look if you scan the QR code on that slide, or you can always drop me an email. My email address is on there if you wanted more information, and you know, get in touch with me after the session. I will drop the link for their study into the chat as well. And then if anybody's interested, you can by all means have a look at it. Participation is completely voluntary and it's not connected to this workshop in any way. So if it's not for you, please feel free to completely ignore this slide. It's enough from me, and just to say thank you. And I hope that you leave today's session knowing that you feel a bit more closer to succeeding, and you're definitely not doing this alone, and you are far, far more prepared than you think you are. So thank you for your time and your attention, and there we go, we're done.
Oh, thank you, Steffi. Thanks a lot for your help and for your support for us.
You're welcome.
Okay.
It's always a pleasure. So
Thanks a lot.
I'm going to stop the recording. Yeah.